Welcome to the image analysis of the shoulder. We will be reviewing image analysis guidelines for the AP projections, the neutral, AP external view, and the AP internal view. We will also review image analysis guidelines for the AP oblique Gracie and scapular Y. In addition, we will review common positioning errors and how to take corrective actions. Image analysis guidelines for the AP shoulder projection state that the scapular body demonstrates minimal transverse foreshortening and half of the superior scapular body is visualized without thorax superimposition. The clavicle is demonstrated with minimal longitudinal foreshortening and with the medial clavicular end positioned next to the lateral edge of the vertebral column. The glenoid cavity is partially demonstrated with the humeral head superimposing it in a non-dislocated shoulder. The scapular body is demonstrated without longitudinal foreshortening. The mid-clavicle will superimpose the superior angle of the scapula. The humerus is demonstrated without abduction. In a AP projection of the shoulder with the humerus positioned in the neutral position, the greater tubercle is partially seen in profile laterally, and the humeral head is partially seen in profile medially. In a AP projection of the shoulder with external humeral rotation, the greater tubercle is seen in profile laterally, and the humeral head is in profile medially. When performing this projection, you will always want to label the projection with a annotation for external projection. In an AP projection of the shoulder with internal humeral rotation, the lesser tubercle is seen in profile medially, and the humeral head is superimposed by the greater tubercle. Additionally, if you are performing this projection, you want to make sure you are labeling the projection appropriately for the radiologist. Regardless of the humeral rotation, the AP projection of the shoulder should include the glenohumeral joint, the clavicle, the proximal third of the humerus, and the scapula. Here are those image analysis guidelines for your review. To evaluate a properly positioned shoulder projection, we want to begin by assessing the scapular body. When there is mid-coronal plane tilt, the scapular body will be demonstrated with longitudinal foreshortening. In the case where the mid-coronal plane is tilted anteriorly, if you take a closer look, you will see that the superior angle of the scapula will be demonstrated superior to the mid-clavicle. This is how you are able to determine if that mid-coronal plane is parallel with the IR. In this case, it is not, and we would need to take a repeat projection because we are not adequately visualizing the scapular body. When there is mid-coronal plane tilt posterior, where the patient is leaning posteriorly, again, you want to assess the scapular body positioning. In this case, the superior angle of the scapula will appear inferior to the midclavicular or midclavicle. Again, you would want to repeat this image in order to properly position for an AP projection of the shoulder. Now that we've talked about how midcoronal plane tilting affects the AP projection of the shoulder, let's take a look at how torso rotation affects shoulder projections. When the torso is rotated towards the affected shoulder, you'll notice several key changes on the projection. The medial clavicular end will appear rotated away from the lateral edge of the vertebral column. There will be increased superimposition of the thorax over the scapular body. The clavicle will appear foreshortened, and visualization of the glenoid cavity is reduced. Now, when the torso is rotated away from the affected shoulder, the medial end of the clavicle will appear to overlap or superimpose the vertebral column. There will be less thoracic and scapular body superimposition. The clavicle will appear less foreshortened, and the glenoid cavity becomes more clearly visualized. These changes are important to recognize as they directly impact image quality and diagnostic accuracy. Go ahead and review this practice analysis and answer the following question. So let's take a look at this practice analysis together. First, we want to assess the position of the scapula. And looking at it, we can see that the superior angle of the scapular body is positioned above that mid-clavicle. This should indicate to you that we have some plane tilt because it should be in line with the mid-clavicle. In this case, we have some midcoronal plane tilt anterior. To correct this imaging error, we want to ensure or realign the midcoronal plane parallel with the IR. You also want to look for any rotation. So you want to look at the position of your midclavicular end in relationship to the vertebral column. In this case, it is aligned parallel next to the vertebral column, indicating no rotation. So therefore, there's no corrective action needed for that. Go ahead and review this practice analysis and answer the following question. Let's analyze this shoulder image together. Two areas of interest that we really want to hone in on is what is the positioning of the scapular body and what is the positioning of the clavicle. In this case, the medial end of the clavicle is rotated away from the vertebral column. The glenoid cavity is in partial profile. The supralateral scapular border is superimposed by the thorax. The clavicle is foreshortened on the affected side, which is indicating to us that the torso is probably rotated towards that affected side. Also, we can see that the greater tubercle is in profile. If the arm rotation remains the same, the greater tubercle will shift to partial profile once the rotation issue is corrected. So if this is supposed to be a neutral projection, we will obtain the appropriate positioning. However, if it is an external view, then we need to make sure we have that arm positioned humerus positioned appropriately. In order to correct this positioning error, we need to rotate the patient away from the affected shoulder to achieve a true AP projection. We want to make sure that both shoulders are equidistant, either standing or when the patient is on the table, and the mid-coronal plane is aligned parallel with the IR so that we ensure there is no tilting or rotation. Go ahead and review this AP shoulder practice analysis and answer the following question. So now let's review another practice analysis together. Again, you want to assess the position of the clavicle and the scapula when assessing an AP shoulder analysis. The scapular body appears drawn away from the thorax and is transversely foreshortened. There is increased visibility of the glenoid cavity in this projection. The medial end of the clavicle is superimposing over the vertebral column. These findings all indicate that the patient was rotated towards the unaffected shoulder. In addition, the superior angle of the scapula is positioned above the mid-clavicle, which should indicate to you that there is some mid-coronal plane tilting here, anterior. Also, the lesser tubercle is seen in profile with the humeral epicondyles perpendicular to the IR, which this confirms the image to be an internal rotation. In order to correct this imaging error, we need to rotate the patient towards the affected shoulder to achieve that true AP projection. We want to ensure that both shoulders are equidistant from either the table or the upright bucky, and align that mid-coronal plane parallel to the IR. These adjustments will restore proper alignment, improve anatomic visualization, and reduce distortion. Let's move on to the AP oblique projection, Gracie method. Image analysis guidelines for the AP oblique projection, Gracie method, state that the glenoid cavity is demonstrated in profile and the glenohumeral joint space is open. 1/3 of the coracoid process is superimposing the humeral head. The glenoid cavity is shown without thorax superimposition. The clavicle is longitudinally foreshortened and is horizontally situated. In a patient who is recumbent, the glenoid cavity is situated slightly superiorly, and the clavicle is foreshortened, aligned vertically, and superimposing the scapular neck, as you can see in this example. For this projection, the superior margin of the coracoid process should be aligned with the superior margin of the glenoid cavity. The glenohumeral joint should be demonstrated at the center of the exposure field. The glenoid cavity, humeral head, coracoid, and acromion processes and lateral clavicle are included within the exposure field. Here are those image analysis guidelines for your review. So let's take a look at the effects of incorrect torso and shoulder rotation on an AP oblique Gracie method projection of the shoulder. First, an excessive torso and shoulder rotation where the patient is rotated more than necessary, the glenohumeral joint space will appear closed. You'll also see that more than 1/3, about a 1/4 inch of the lateral coracoid process will overlap the humeral head. This indicates excessive obliquity. Now let's look at what insufficient torso and shoulder rotation looks like. If the patient is rotated less than is needed, the glenohumeral joint space will appear closed, okay? But in this case, less than 1/3 of that coracoid process will overlap that humeral head. This under rotation results in poor demonstration of that joint space and compromises the diagnostic quality that we are aiming for. It is important that accurate patient rotation is achieved so that we can open that glenohumeral joint and properly demonstrate that shoulder anatomy. Go ahead and review this first practice analysis and answer the following question. So let's take a look at this practice analysis together. We want to look at two key pieces of anatomy here. Is our glenohumeral joint space opened, and what is the position of our coracoid process? In this case, the coracoid process is superimposing less than that 1/3 of the humeral head. The glenohumeral joint space is closed. The clavicle is demonstrated as foreshortened, and this all should indicate to you that we are insufficiently obliqued. In addition, the superior margin of the coracoid process is positioned above that glenoid cavity's superior margin. This should also indicate to you that there's a little bit of plane tilting occurring here posteriorly. In order to take corrective action, we need to increase patient obliquity and align that mid-coronal plane parallel with the IR. Go ahead and review this AP oblique shoulder and answer the following question. Let's review this practice analysis together. We want to look at the positioning of the coracoid process in relationship to the humeral head, and is the glenohumeral joint space open? And in this case, it is closed once again. The coracoid process is superimposing more than that 1/3 of the humeral head. The clavicle demonstrates excessive foreshortening. This should all indicate to you that the patient was excessively obliqued. In order to take corrective action, we need to decrease the degree of patient rotation in order to get a more accurate AP oblique shoulder projection. Now let's move on to the scapular Y, PA oblique projection. Image analysis guidelines for the PA oblique shoulder projection or scapular Y state that the scapular body should be demonstrated in a lateral projection with superimposed lateral and vertebral scapular borders. The scapular structures form a Y, with the scapular body as the leg and the acromion and coracoid processes as the arms. The glenoid cavity is demonstrated on end at the converging point of the arms and leg of the Y. When there is no injury, the glenoid cavity and humeral head and the scapular body and the humeral shaft are all superimposed. When there is a shoulder dislocation, the glenoid cavity does not superimpose the humeral head. When there is a proximal humerus fracture, the glenoid cavity superimposes the humeral head, but the scapular body does not superimpose the humeral shaft. The scapula should be demonstrated without longitudinal foreshortening. The clavicle and superior scapular angle are visualized at the same transverse level. The mid-scapular body should be demonstrated at the center of the exposure field. The scapula, including the inferior and superior angles, the coracoid and acromion processes, and the proximal humerus are all to be included within the exposure field. Here are those image analysis guidelines for your review. When a true lateral PAY projection is not obtained, it's important to be able to identify the scapular borders to evaluate your positioning. The lateral border of the scapula appears thicker with two distinct cortical outlines, typically separated by about a quarter inch. In contrast, the vertebral border shows only a single thin cortical line. Recognizing these differences helps confirm which scapular border is visualized and whether the image needs to be repeated for proper lateral positioning. This also will help you determine which direction you should rotate a patient in order to get that true lateral projection. We will discuss in the upcoming slides. So let's review how to recognize excessive rotation, where the patient is rotated more than that 45 degrees, or insufficient torso and shoulder obliquity for the PAY projection. In excessive obliquity, if the lateral border of the scapula is superimposed by the thorax or appears closer to the thorax than the vertebral border, the patient is over-rotated. This is indicating the patient is excessively oblique. In this case, the glenoid cavity will rotate in the same direction as the lateral border, which can distort the joint space. Now, in insufficient obliquity, where the vertebral border is the one superimposing the thorax or is closer to the thorax than the lateral border, the patient is under-rotated, meaning the obliquity is insufficient. Again, the glenoid cavity follows the direction of the lateral border of the scapula. So improper alignment will compromise the visualization of the glenohumeral joint. proper rotation to that 45 degrees is essential to achieving a diagnostic image with accurate anatomic relationships. Go ahead and review this first PA oblique scapular Y practice analysis and answer the following question. So let's review this practice analysis together. We want to look at the quote-unquote leg of the scapular Y, which are their lateral and vertebral borders of the scapula, and determine if they are superimposed. In this case, they are not. Also, the glenoid cavity is demonstrated laterally. If you take a closer look, you can see that the lateral border of the scapula is demonstrated away from the thorax, and the medial border is closer to the thorax, indicating that we haven't sufficiently rotated the patient. So we need to increase rotation in order to obtain a true PA oblique scapular Y projection. Go ahead and review this next practice analysis and answer the following question. So let's review this practice analysis together. In looking at this projection, we want to look to see if the scapular borders are aligned. In this case, the leg or the scapular borders are superimposed. However, we do have a little bit of a positioning error. If you take a closer look, and you can see that the superior angle of the scapula is positioned superiorly to the clavicle. This should indicate to you that there is some coronal plane tilt. Typically, when patients are rotating for this projection, they are tilting forward. So you need to make sure that that mid-coronal plane stays aligned parallel with the IR to get that true PA oblique scapular Y projection. Otherwise, this will foreshorten your scapula. Go ahead and review this last practice analysis and answer the following question. So let's review this last practice analysis together. Again, you want to look at the positioning of the medial and the lateral and vertebral borders of the scapula. In this case, they are not superimposed again. If you look for the border that is thicker, you can identify that as the lateral border, which is positioned closer to the thoracic cavity. In addition, we know that the glenoid cavity will move with the lateral border, and it is demonstrated medially and not on end. This should indicate to you that we have excessively rotated the patient. In order to take corrective action, we need to decrease that patient obliquity to that 45 degrees in order to obtain a true and accurate and diagnostic image. This concludes the image analysis on the shoulder projections. If there's any questions, please feel free to reach out.